And I'd like to introduce Emily Lister, very long-lived colleague here in transplant. Take it away, Emily.
We talk a lot about heroics when we talk about transplant, whether it's the deceased donor family who's made a decision at an incredibly difficult time in their lives, for someone to be an organ donor, to make transplant happen for someone. We have the heroes of living donors, you'll hear more about that, I think, later today, who make the very brave and loving choice to be a donor. We have our surgeons and team members who are heroes every day. But I think one of the unsung heroes of the transplant experience are the care partners. And again, Dr. Kavanaugh touched on this several times in her talk about the importance of the care partner in the process. And so we want to talk more about that. And the best part of this upcoming discussion is that we have some wonderful guests who will be joining us virtually from the Roanoke area to really talk about their experience and care partnership and the journey of transplant. So I'll get my stuff out of the way so you can get to the good stuff. But I'll start with kind of a irrelevant story somewhat, but it did come to mind as I was thinking about these slides. I got a call from a neighbor not terribly long ago, and she said, I got to ask you a favor. I have to go for this medical procedure, and they told me I can't drive myself home. And I hate to ask you, but could you do it? It's like, okay, sure. So it was no problem. So I picked her up. But as I was sitting there waiting for her, I thought, I was happy to help her that day. But then as I was thinking about kind of work and transplant and care partners, I thought, what if she said to me, can you bring me once a week? Can you pick me up once a week from my appointment? Or if that call came in the middle of the night, I don't know that I could do that. And so it really made me think about and it's where I ask you to kind of keep that framework in your mind as we talk about this and sort of the heavy lift and what we talk about when we talk about criteria for care partners. So let me put my little clicker here. So, why do we talk about it? Maldonado out at Stanford, who actually authored the and was kind of the lead investigator and creator of the SIPAT, which is the psychosocial screening tool that we used for transplant. So he created that. So I think he has some of the better overview articles on this topic. And, he talked about, why is it important? He just touched on how there's a strong association between pre-transplant psychosocial vulnerability and post-transplant outcomes, much like Dr. Kavanaugh was discussing. And there are an abundance of studies that talk about and validate the role of support in transplant success. And in some studies, Mary Mandadu and some others looked at some years ago, I think it's a little bit old now, but I think still important to talk about, that social support is one of the most important factors in predicting transplant success. So some of the key pieces that Maldonado talked about that I think are important and we'll kind of keep coming back to is that, the transplant process is arduous and lengthy. I thought those were two descriptive terms. It's not a matter of picking up someone once from an appointment. There's a pre-transplant and those are the pre-transplant evaluation process that sometimes can mean many appointments. There is, and even when someone is listed, there's the follow-up annual listing visit that can go on for years. If we're talking about someone who's waiting 5 to 7 years for a transplant, there can be many of those appointments. The surgical event, the transplant event where someone could be in the hospital maybe just a few days, but if there are complications, someone can be in the hospital for weeks or more. So there's that phase, and then the post-transplant phase. You're coming back to the transplant clinic once a week for a while, and then, appointments, depending on what someone's needs are after that. Rides to get your labs done, and even if a transplant recipient is able to drive, they're restricted against driving, for about at least a month or so. So it's not a one episode, can you pick me up from my appointment, kind of ask. So it's arduous and lengthy. Now, I think something that's different, especially when we start to compare transplant to perhaps dialysis centers, is that it's really unlikely that the transplant center, our transplant center, is close to someone's home. So again, whereas that ride to dialysis might be a mile or a few miles, we may be 300 miles. So it's not likely as close as your typical, can you pick me up from an appointment, 10 minutes away. You build in a much longer kind of geographic ask there. And this is a little bit of a clumsy statement, but I think it's important. Transplant surgery is not the definitive treatment in itself. The care needs continue. So if you have your knee replaced, there's a critical pathway that most people follow, and that surgery is the treatment. Whereas with transplant, that can vary. You have your transplant surgery, but you may need to come for infusions, for example, and or biopsies. So it's not as if the transplant surgery itself is the end of the process. So I think that's kind of a sort of a vague concept, but I think one that's important. Another part of this I think is important that Maldonado talked a bit about was that hospital support resources cannot serve all the needs. And we do our best to support patients in every way we can, whether it's lodging, meals, helping arrange transportation. But there are limits. There are limits to what we can do just realistically. And as in this article, he talked about, we can help arrange, the hospital and our social work team, we can help arrange, for example, transportation, but who is helping that person get ready, get dressed, know that they have something nutritious to eat before they hit the road for the appointment? So there can't be a total reliance on the support from our hospital resources. Again, we do our best and we try to make those resources available, but it's not the entire answer. So the support system has to be there as that safety net. So I saw this cartoon and I thought it was really appropriate for this discussion because, we'll meet a patient for the first time. They're like, I have great support. I have Uncle Bob and my neighbor Jane, and I've got what I need. But I think this says a lot too. Sometimes it's a bit of a circus act, and we really have to really assess further. Quantity isn't everything, as we well know, and so we do have to do a deeper dive into what that support system really looks like. So we'll talk about that a little bit more as well. So this is just a quick overview or some of the key concepts of the criteria for care partners. And one is that a care partner attend the evaluation appointments and the annual list maintenance appointments. Sounds simple enough, right? But we do have a lot of patients that show up for their initial visit alone. Sometimes they've driven themselves, sometimes they've taken public transportation and show up alone. And so we will always have the requirement that someone come back with their care partner. And sometimes that comes across as being a little bit too strict. We've gotten that feedback from time to time. What do you mean I have to come back with a care partner? I have to come all the way back to clinic? Yes, and we do really, really feel strongly about that. And I see at least one social worker over there nodding. It may seem to be a little bit too strict, but we really need to have that in-person time with a care partner, to meet them, to get a sense of their readiness, to get a sense of their willingness and from a practical standpoint, what they're able to do. And we'll talk a little bit more about that, as we talk about this. And providing transportation for the organ call-in, follow-up, ER, urgent care visits. We need to know who that is. Now, sometimes the care partner is the one who may be doing the more hands-on help, say in their home setting when they get back. Maybe that person doesn't drive, or maybe that person may have some other limitations. But as part of the care partner framework, there has to be a transportation plan for organ call-in follow-up appointments, ER urgent care. We'll talk about this a little more detailed in a moment, but I just want to get through these other basics. Participate in the transplant discharge education. The care partner can't just drop off someone for transplant and then not come back until it's time to pick them up. That's not to say that a care partner has to be there every minute of every day of the hospitalization. We know that life goes on at home, whether it's children, pets, jobs. There's not a requirement that someone be there every day. So there would be coordination with the care partner, but to be able to be that other participant in the discharge education, pharmacy education, and so forth. So when someone gets home, there's been another set of eyes and ears learning all that information. Again, we'll talk more in a second about it. We really need folks to have someone who's there 24/7 those first few weeks post-discharge from the transplant admission. Again, it can be someone else other than that primary care partner, but we sort of look to that primary care partner to be the coordinator of that. Maybe it's some neighbors, friends, other family members who take turns. It doesn't have to be the same person all the time, but that care partner needs to be the point person who is sharing with the others the information they have learned in the discharge teaching and so forth, so that someone does have that presence in those first few weeks. And then from a, very literally hands-on standpoint, ability to assist with lifting and driving. Ideally, someone after transplant will return to those activities, but can't lift more than typically 10 pounds for a while and can't drive for some weeks after. So again, there's that practical piece of it. And the other, providing emotional support and encouragement. And that can sometimes be the toughest thing, when you're really tired from being all those other things, to really be able to encourage. And we'll talk a little bit more about caregiver self-care in a little bit. So again, that's a big ask. That's a heavy lift. It's much more than picking you up once. So a little bit more, just to do a little deeper dive into those points. At least one identified care partner must attend the main Charlottesville transplant clinic appointments. And something where we, and many of you may know that we have a number of outreach clinics where we meet many of our new evaluation patients. Arlington, Lynchburg, Martinsville, Newport News, Roanoke, Wytheville. If someone has come with them, even to those outreach appointments, we do still require that they come to Charlottesville. Again, sometimes we get feedback that that's a little unfair or a little too much to ask. But something I often say is that if you get a call for transplant at 2 a.m, that's not the time that your support person, should be learning the way to Charlottesville for the first time. And many folks that we meet have never been to Charlottesville, much less UVA. And in the heat of the moment, when you're called in for transplant, is not the time to be learning those things. So at the very least, it's a bit of a dry run of how to get to us, how to access our buildings, our parking, which we always get great feedback about that part. So it's just important that care partner attend the Charlottesville appointment. I know you're wondering why I say that so much. It's because it always comes up as an issue. Do they really have to come? We get that call, all the time, right? They can't come today. Do they really have to? And yes, and we'll work with you. We'll work with patients to find times and dates that are good for their care partner, because we know that with work and other obligations, it can be tough. The transportation piece. So the need for transportation, again, can occur at any time, day or night. So that availability to be able to be nimble and take that call at any time. And there must be a licensed driver with access to a vehicle. So it's not enough, and I'll go back to Dr. Kavanaugh's comments about asking open-ended questions. It's not enough to say to a care partner, do you drive? Well, the answer might be yes, but that doesn't mean that someone has a license to drive or has access to a car. So the question of can you drive is not adequate. We have to, again, have a lot of follow-up questions. Are you licensed? Do you have access to a vehicle? Can you drive at night? That's another limitation we often will run against in talking to care partners. So if the main transportation or care partner can't drive at night, you have to have that backup person that can be your nighttime person if you need that. Another response we often get is, well, I don't need someone to drive me. I have Medicaid transportation. Well, and that's great that resource exists, and we certainly our patients utilize that quite a bit. But it can't be the primary plan for transportation. It's not something you can get the last minute typically, or in the middle of the night. That's not to say that someone can't use Medicaid transportation to get back and forth to appointments. Don't get me wrong, but it cannot be the primary transportation plan. We do have some gas card assistance that we can offer to patients who have financial hardship, especially with gas prices the way they've been. But it's not guaranteed. We do have a finite stack of cards at any time, and sometimes we run out. So we do try to make it available. Again, it's not something that someone can rely on at every visit. Any questions about that piece? Because we get a lot of questions about it. We've already talked on some of this. No requirement that someone stays for the entire hospitalization. But again, the inpatient unit leadership will coordinate with the care partner about when to be present for discharge teaching and so forth. We can, the social work team can talk with, and we do talk with patients and care partners about lodging options. UVA does have a contract with a local hotel, and we can make lodging available. There are some limitations to that in terms of distance from the hospital. Typically has to be more than 60 miles that someone lives. And there's some other limitations to that, but we really do try to make that available. I will say, as with any hotel accommodation process, there are guidelines. No pets, that's one that has come up just recently. And I will say, if a care partner or family or patient even, if they don't follow those guidelines, that the option for utilizing the lodging option in the future, the courtesy lodging, will be revoked, and it happens, and that's a really, really, really difficult conversation to have with patients. So we just have to be very mindful of the guardrails with that, but it is something that we try to offer. And again, oops. Okay, I'm not going to go back. Sorry. The other piece of it, just in terms of special considerations, if you will, and all that. Again, the distance to and from Charlottesville. And I will say this discussion often comes up in our outreach clinics. We have these great outreach clinics that are closer to home for many people. But the transplant itself still takes place at UVA in Charlottesville, as does the initial follow-up. So those weekly visits in clinic at first, that does still take place in Charlottesville. So I think that, especially in our outreach clinic areas, we just continue to need to manage expectations that there are those back and forth trips to Charlottesville for a while. Again, the goal being that after some time that follow-up care in those outreach clinics is possible, but not at first. So again, we want to be very realistic with that. Again, the unpredictable nature of the call-in and follow-up trips. Again, the call to come in for transplant can happen in the middle of the night or on the weekend, or there may be a need to come back to our ER for evaluation post-transplant if there's a complication. So it's not something where you say, okay, pick me up from my appointment, or even can you take me to dialysis Monday, Wednesday, Friday? There's no real predictable nature when we talk about care partner needs and transportation needs for transplant. Plan for time off work, childcare, and other arrangements. So if the care partner is here in Charlottesville for some time during the hospital stay, for example, or follow-up complications, the care partner really has to do a lot of their own work to plan for time off work and care for children or pets or for those times. I will say here, I wanted to point out a couple things. And one is that there's often a misunderstanding about FMLA and who can use that. So someone will be a care partner, say, for example, for their best friend. And when you ask about time off work or protecting your job while you're being a care partner, oh, I'll just take FMLA. Well, FMLA is very limited in terms of the relationship and when that can be used. Now, what conversation a care partner has with their employer and their HR, I mean, their HR departments can do what they want, but in terms of FMLA, sort of by law, your best friend isn't one of the qualifying relationships on the list. So that's an important piece. Something I'll say here, probably should have brought it up before, but I'll go ahead and slide it in here, is that the topic of a paid caregiver. And that's something that comes up too, is a patient who says, well, I live alone, I don't have anyone to help me, I'm just going to hire someone. And that's fine, right? Actually, no. And so again, there's often a lot of argument back and forth. Well, what do you mean? If I hire someone 24 hours a day, why isn't that enough? And reasonable question on its face, but our position is that a paid caregiver, that reliability is not always there. So if that paid caregiver is sick or has a sick child, will they show up? If the rates go up, will you be able to still manage that? Now, we don't do an in-depth sort of financial analysis on that. So how long can you afford to have 24-hour day care? But we know that other than extraordinary situations, that's going to become a pinch for most people after a while. So it may sound good, or you may think, okay, yes, I can hire someone 24/7 for the first 2 weeks. But what if you have major complications and that need for care goes into 6 weeks, 8 weeks, 12 weeks? Will you still be able to pay for that care? If someone makes the same argument that they have Medicaid personal care or direct care provider, or would be able to qualify for Medicaid care, again, we all know, you just turn on the news any day and hear about cuts in Medicaid and cuts in programs. So again, not something you can rely on. So with anything we've talked about, the paid version is not enough. And again, that may sound a little cruel. But there's got to be that network of family, friends, others who can be the primary. It's not to say that you can't hire someone or you can't pay for a cab. That's not to say any of that. It just can't be the primary. So any questions about that? Because, again, I feel like that keeps our phone ringing a good bit. Okay. Oops. Going back to the last part of that last slide talked about interpreters. And so we do have interpreters, ideally in person, especially during the initial visit. It's just nice to have that consistency, to have one live interpreter. If we can get that, but again, those options are limited. I'm looking at Danny because I know that you guys coordinate that. We have some great interpreters who can be live with us in clinic and follow a patient during their entire initial visit. But we often are relying on Globo, either on the phone or by the video screen. And all of the support education and all of this is available in English and Spanish, and we can get other translation as well. Let's see here. Make sure I didn't skip something. And with this piece, I just wanted to touch on everything I've talked about is just a lot. It's a lot for someone to do. To be that go-to person for appointments, to be that person who's giving that encouraging word at bedside, coming to visit, bringing your favorite blanket or whatever you might want in the hospital, dealing with that middle of the night trip to the ER when you suddenly have a fever and your urine output isn't what it needs to be. So crucial for care partners to be able to take care of themselves. And I think anyone who's been in a care partner role knows this firsthand, that sometimes you feel guilty saying, I need some time. Can someone else be here for a little bit because I need a break? It's one of the hardest things to say or do for yourself, but it's not a luxury, it's a must. There are a lot of cliches out there, but I think they're very true. You know, you can't serve from an empty cup, or, you know, the airline example of you have to put your own oxygen mask on first. There are lots of other little sayings like that, but they're true. You have to have a backup. I will say we don't absolutely require a secondary care partner to be listed for kidney transplant. It's not that way on other organ groups. There is a requirement for a secondary care partner. We've stopped short of that on the kidney side for now. I think it's always going to be up for discussion. But it's really important, whether we require the secondary care partner or not, that a care partner have a backup of some sort, whether it's the transportation piece or being able to run an errand or drive. Again, I've had many primary care partners say to me, I'm fine, I'm healthy, we don't need a backup. You can always trip on your way out today and break your ankle or get the flu and just not be able to do it. So it's just crucial to have that backup. And also engage with support, being able to connect with other caregivers if possible. We have a support group, then caregivers, care partners are invited to be part of that. Seeking out support from others. Sometimes that's accidental. You run into people in the waiting room or at the Hampton Inn where a lot of our patients stay. Some of that engagement with support is accidental, but so important to be able to have someone to talk to make this journey one that everyone can manage. And making time for sleep, nutrition, exercise, hobbies. Again, it's not selfish. It's so important to do. With that, before we get to introduce and visit with our wonderful guest and panelist, any questions? Any questions? Yeah.
So let's say you have someone come back post-transplant and they are doing well mentally, all emotionally, but the care partner is really struggling.
Yeah.
Do you guys refer them to resources, like maybe other than the support groups,
Yeah.
to address the care partner mental health?
That's a great question, and certainly any of us are available to, let someone know resources in their local area, or sometimes, if that care partner has a PCP they have a good relationship with, that sometimes is a really good place to start, to ask, to suggest that they talk with their PCP. I've often, a number of times have suggested for care partners that they connect with their EAP at their work, because sometimes this part of that burnout and stress has to do with a number of factors, but often it's, I'm really stressed about work and feeling like I'm not there enough. I'm pulled in so many different directions. So if that care partner has an employee assistance program, because I can often offer, no or low cost options. So we really do try to be attuned to how the care partner's doing. And of course, since they're not, that gets a little tricky because they're not our patients per se. So there's some limitations with that, but really do try to connect with resources as we're able.
Thanks. Do you guys have an age restriction for how old the caregiver can be? Because I feel like sometimes
Yeah.
we see pushback on like grandparents wanting to come forward, like 75 to 80 years old.
To be a care partner.
Yeah.
That's a great question, and again, we certainly have our, every day dealing with questions like that. That's where we do get a little more insistent that there be a secondary care partner. We have, I can think of some situations we've dealt with recently where we have kind of broadened the discussion about the paid piece being oftentimes the backup, even especially if the primary care partners are more advanced age. There's not an age limit. It's more about how
Functional?
just their functional status, cognitive status. And again, it gets tricky because that care partner is not our patient to be able to assess things like such as maybe dementia. If you've got someone who's putting themselves forth as a primary care partner, but you have concerns about maybe that person's cognitive potentially decline, how does that look? So that pushes us more towards saying case by case that there has to be a secondary care partner.
Okay.
So, great question.
We have an online one.
Oh, okay.
From online, how often do you check in with care partner during evaluation listing process to ensure stability and availability?
Terrific question, and always a challenge. We have many hundreds of folks on our list, for example, and so there is the structure that we have is the beginning part of the structure anyway, is the annual list maintenance visit. And so we do ask the care partners to come back for that. And so if someone comes for their follow-up appointment and that care partner is not with them, we want to know why. And, again, sometimes it's, she has the flu. She couldn't come today. So we will follow up with a phone call. So if that care partner is not present at that built-in follow-up appointment, we'll ask some more questions. And sometimes, a lot of times it's something as simple as they had a fever, they couldn't come today, or they had to cover a work shift unexpectedly, couldn't come today. So we would follow up with a phone call. So we do get concerned if the care partner plan changes a lot. So sometimes, say we'll meet someone in our outreach clinic and they show up with one care partner. Well, 3 weeks later, when they come to Charlottesville for the appointment, it's someone else. And then when you make a follow-up call, that someone else is no longer in the picture, then it's someone else. So that's, again, when we want to look a little bit more deeply at the patient's just kind of the cadence of their life. And, why are all these changes? Is this a good thing or a bad thing? Sometimes it's good. It means there are a lot of people that can help. But sometimes it might be a little more concerning about maybe their housing stability or just other maybe red flags with that. So so the answer, getting back to the question, is we have the yearly evaluation appointment, and we want to see the care partner at that yearly appointment. And if they're not there, then we're going to pursue that and just figure out why yes or why no, because that will sometimes lead us to, I wasn't there, I just can't do this anymore. I no longer, my vision has gotten worse since last year and I'm really not driving anymore. Well, those are important things to know. So that may be the real reason that the care partner wasn't there. So then we may have to, sometimes it may even mean making someone inactive on the list while we sort that out.
Any other questions for Emily? Okay, I think.
So we're so delighted to have Mike and Sherry Brown with us to share their own story and their own reflections. There they are. Their own reflections on, what it means to be a care partner. What are the things that maybe we didn't touch on? What are the things that they might want to emphasize more? And to really, again, bring to life the unsung hero of the care partner. So I'm going to turn it over to them. I'll stay up here in case we have some other discussion points. But I want to turn it over to them. Mike and Sherry, thanks so much for joining us. I know we were maybe a little off time-wise, so thanks for your patience. And take it away.
Emily, we thank you. I just wanted to express our appreciation to be able to speak because I'm going to begin by correcting Dr. Kavanaugh. Dr. Kavanaugh stated transplant's a journey. There needs to be an asterisk out there that says, and it's not just for the patient. And so I'm going to make that statement. But essentially, my experience as a caregiver began after 27 years of marriage when my wife back in 2015 went into kidney failure. And regular lab work, medical appointments, procedures, later providing routine dialysis appointments, and educating myself on what's going on and what we can do about it became a part of life. Attending transplant orientation classes, more medical appointments, more tests to get activated on the list, followed orientation. And all this happens rather quickly. So what was key for me is, and part of it is my engineer brain, is I want to understand how this process works, what the lab results are going to indicate, getting organized and documenting her records is key in understanding what's going to lie ahead and what decisions we're going to need to make. In 2016, she received a kidney transplant. Post-discharge, three trips a week were made to the transplant center. But after a month, the frequency decreases, but within a year, the transplant really wasn't as expected. And due to declining GFR and creatinine, she's reactivated on the list for a second transplant. So then my role as a caregiver really started to change in a different way.
Now, Mike got to go first. So I get to talk now. Fast forward a little bit. Now, keep in mind, I am still adjusting to transplant. I'm going to the transplant center. I'm still doing labs. They're adjusting my meds. Mike has to hold my hand. A lot of times I can't really walk anywhere by myself or do anything. Then everything changes. I became the caregiver in 2016 when Mike had to have one of his kidneys removed due to PKD. So he had the kidney removed and he had his fistula for dialysis started at that time. And since I had already been to orientation class with my transplant, his dad went with him to the second one, which gave us a second caregiver education access. That just gave us more support there. So both of us were now going to the transplant center. We would go to appointments and they would put us in separate rooms and they would say, well, where's your caregiver? And I would say across the hall. And they would ask him, where's his caregiver? And he'd say across the hall. So they finally got to the point to where they would put us in the same room together. They finally got the idea. So lots of appointments, lots of lab work, trying to get all the tests. There's a lot of tests that have to be done. And that involves a caregiver helping you get to those appointments and get those tests done. We had to stay very, very organized to keep it all straight. And I had a binder for each of us, and we kept everything printed, everything. I know electronic, you can go on my chart and get it, but it's just so much easier to grab that binder. And if you need to know what your creatinine is or your GFR or when you started dialysis or whatever, it's all right there at your touch. So I'm going to fast forward a little bit again to March of 2017. Mike starts hemodialysis because his one remaining kidney is just not cutting it. It's just fizzing out. We're fortunate in that he's able to still continue to work full time. He's able to drive himself to and from hemodialysis. I wasn't able to do that. I got very sick. But we're fortunate that he's able to do that. After a while, he was able to switch to PD dialysis at home, which was fantastic. So much easier. He just handled dialysis so much better than I did. Okay, go fast forward again to June of 2019. Mike gets the call for transplant. Our daughter Amy was local at that time and was able to be yet another caregiver to help. She was able to go with him to the hospital for transplant surgery. I was still struggling with the transplant and with the complications of it not working right and medication and lots of things. But Mike does great with his surgery. He did have a small bout with pancreatitis that had to be dealt with, and he had to stay in the hospital just a little bit longer than I did. We're still doing trips back and forth to the transplant center, doing labs, everything. And then in November of 2022, Mike starts having trouble with his other native kidney, his last native kidney, and it has to be removed. So once that is done, I get to say, Tag, you're it.
Yep. So in 2023, Sherry receives a call for her second transplant. And what I can say is, having been through this experience previously, both as a recipient and prior as a caregiver, the caregiver learning the caregiver's learning curve was greatly decreased. However, no matter how familiar you may be with the requirements of the caregiver, the requirements are not to be taken lightly.
The caregiver, agreeing with Emily, the caregiver has to take care of themselves. They also need to be aware of the people around them that, you know, with COVID and flu and the measles and everything else, they have to protect themselves to keep them from carrying that to the patient that they're caregiving for. So again, that is another thing that we impress to anybody that we talk to as mentors, that the caregiver has to be aware of those things. Just have to be careful of everything. We have some more suggestions to share with caregivers, and maybe as partners with the caregivers, you could share this information with them. They need to educate themselves. They need to learn the language. They need to know what GFR means and what CRE means, and the tests that have to be done and what the timing is for those tests. There's a lot of that information that can be found on OPTN's glossary, but you also have your people in the transplant center, your coordinator, your nurses, your doctors. They can answer any questions. Don't be afraid to ask a question. No question is stupid. Take small bites. Ask for a book that's given to post-transplant patients before the transplant happens. If you want to look at it, they'll share it with you. It's not a restricted thing. It's here, you can have it. The other thing that is very important is you have to, as a caregiver, you have to help that patient find a living donor. You have to educate others. As you know, you can live with one kidney, give your kidney to somebody else. A sticker in your car, a flyer in the lemonade stand. Mike and I did, he's trying to show you his Donate Life sticker. Mike and I did Christmas parades. He has a 1971 Pontiac that's bright red, and it has a huge Donate Life magnet on the side. We did every Christmas parade, every possible thing, every car show, everything possible. We had T-shirts made up that said, will you share your spare? And it had a spare tire on it, but they would ask us, and they would say, well, we would say, share your kidney, your spare kidney. There's also peer support out there. There's lots of support groups. Transplant centers are kind of hit and miss about sharing that with patients to let them know that there are people out there. There's mentors out there. There's calls, videos that you can dial in to listen, ask questions. Those are out there. The other thing that Emily mentioned was about FMLA. Yes, there are a lot of asterisks, a lot of yes, you can, or no, you can't. Some companies will let you take it all at once. Some won't let you do sporadic appointments. So you've got to research. A caregiver has to research all of those things. You also need to know and understand the person that you're supporting. You need to know what they want. If something happens, you know, God forbid, something happens and there's a complication, you need to know if they have an advance directive. Is there certain people that they want called, certain things they want done? You need to know that stuff. And you need to have a conversation with the caregiver to say, talk to the patient that you're supporting and make sure you understand what their needs are. If something happens and you get sick and you're not available, who's going to step into your shoes? And that person needs to be educated as well. They need to know how to get to the transplant center, who to call if there's a question. And again, the binder that I made was perfect because all of that was in the first couple of pages. Who to call, what to do, how to handle things. There are many, many, many pre-transplant plant trusts, if I can get my words straight, tests required. You've got to have stress tests. You've got to have colonoscopies. You've got to have cancer screenings and labs and all the things. You need to create a log of those and be able to identify that, okay, I had this test, this stress test, it's only good for 1 year. So don't let it pass. You got to be on top of it. The coordinators do a really good job of trying to keep you engaged and know what's going on. But sometimes it can happen that you don't get it scheduled in time, and that can inactivate the patient off of being eligible for a transplant. Um, it also helps you schedule if you're working a job, scheduling the time off to take them to those appointments. There's lots of post-transplant, so it's not just surgery and you're done. There's lots of post-transplant work to be done. There's a lot of medicine adjustments, a lot of tests. Sometimes there's CTs, there's biopsies, lab work. Some of those things can be done at one of what we call the satellite office here in Roanoke. We spend a lot of time there. But sometimes you have to go straight to the transplant center, which is over a 2-hour drive for us. 2 hours there, 2 hours back. Small things can add up. Keeping a bag packed. People don't think about having a suitcase packed. And it's kind of funny, but when the time changed, each year, because I waited several years for my transplant, every time the time changed, we refreshed the packing bags, or if the seasons changed, because long pants versus shorts and all of that, you have to keep your bag packed and at the door, ready to go, grab and run. Keep the car gassed up. Keep your cell phones charged up. Have battery banks. Where are you going to stay the night? Save the hotel listings in your phone. Have them ready. And again, post-transplants, your requirements change daily of whatever you need. You have to make sure that you have some place to stay locally, close to the transplant center. You've got multiple trips per week right after the transplant, because they've got to make sure everything's going along, no rejection, no conflicts with your medication. Keeping your medicine organized and documented, how many pills you take, when you take them, setting an alarm on your cell phone to say, hey, it's time to take my pills, is very important. The other thing that is critical is, and Mike and I both learned this being caregivers for each other. I love him. I've been married to him for 38 years, but there's times that you have to step back and you have to be the caregiver instead of the wife or the husband. You love them, but sometimes you have to be tough. My daughter would come to the hospital, and yes, she loves me and I love her, but she would say, Mom, you got to get out of bed. It's time to get up. Let's go. And sometimes you got to be the drill sergeant. You haven't eaten anything today. It's time to eat. You just got to keep in mind, you've got two roles there. You can't just say, well, he'll be okay.
No.
No, can't do that. You have to say, no, it's time to go. Know that transplant surgery is it's a major procedure. It's a big thing. That caregiver role is vital. You can't do it without a caregiver. There's no way. And the caregiver role, like for Mike, was a little different with my second transplant than it was my first, because we had my daughter here that was able to help me with the second. We kind of knew what to expect and what to do. But you've got a lot of caregivers that have no experience at all. They've just been asked to step into this role and they have no clue what needs to be done. And then Emily mentioned the oxygen mask, and it's funny because we had written that in our notes as well. When you're on a plane and there's a problem, you have to put your mask on first. And as caregiver, you got to put your caregiver mask on first before you can help the patient. So you do have to take care of yourself. You can't help somebody else if you're sick or you're down or you've got emotional issues or whatever. You have to be able to be strong for that person. They can't do it without you. And you need to also be able to speak up, raise your hand if you need help. So,
In our community,
Thanks so much
through the
for,
parades, many
sharing that.
people will approach us as both a caregiver or someone awaiting transplant, but it's a wonderful way to give back. Any questions?
Any questions from the group or online? Mike and Sherry, we appreciate your insight so much. Love the insight into just sort of the experience and emotionally, and also the practical tips. Those are great tips about the changing the bag to make sure it's seasonal, and other practical tips. Those are terrific, and we'll all take those back with us. Any other questions from anyone?
Yeah, we have a guest here who's asking, how are you both doing?
You first, ladies first.
I'm doing fantastic. Now, because I had to wait so long, well, the first kidney really just took me off of dialysis for a short period. And then I had to wait again to get the second kidney. So it's taking me a little longer to bounce back. My muscle mass, my stamina is lower, and it's taking me time to build that back up. Now he had his transplant and he was walking laps around the floor on the hospital just a few hours past that. But he's a lot stronger than I am, and he didn't have to wait as long as I did. And I think too, where my kidney failure came out of the blue, he had a little more time to understand and educate himself on the PKD side of it. But both of us are doing great.
I'll say this, through dialysis, I had a goal that if I make it through this and get my transplant, I'm going to make this goal. My goal was survival, but my bonus, I'm going to make it reality. And every year for the past 6 years, I get to participate in a fundraiser that is my bonus. And I'm just blessed. I can be enjoying my hobby and I have to stop and go, X years ago, I just physically couldn't do this. But I appreciate whoever's asking because I'm blessed.
And as for my bonus, I get to go to Disney,
All right.
where I
Thank you
couldn't
so
before.
much. Thank you. Thank you.
Thank you.
I did see a question pop up online about, is there a national, I forget what it said because it's gone now, but a National Care Partner Peer Contact Info site. Mike and Sherry, correct me if I'm wrong. I don't know if something that specific, but certainly the National Kidney Foundation and some of the other transplant education sites, even UNOS has some caregiver information. And that's where I would start. Mike and Sherry, I don't know if you know of others through, I know you've been so involved in various transplant organizations, but in terms of a care partner site per se, I don't know, but I would start with the National Kidney Foundation and kind of weave through their channels to get some other thoughts.
In many social media groups, there is an effort to have direct communication. But one thing that I do encourage with UVA's monthly abdominal transplant meeting is not just post-transplant, but pre-transplant patients attend and participate and ask questions. And the other thing is being a UVA transplant mentor, have the caregiver ask questions. It's not just the patient that's full of questions and wants encouragement.
Yeah, and I think that's a great, again, a great sort of task or challenge for us to take back to is how do we further engage and more engage with care partners as part of our support group and other efforts. So thanks for that, and we definitely take that back today. Thanks so much, Mike and Sherry.
Welcome. You're welcome.